I suppose that is our cue. Good afternoon, everyone. My name is Bill Alder with Weedy. Happy to have you join us here for today's Weedy Virtual Spotlight. 3 risk adjustment moves to make now, given policy changes and compliance scrutiny, presented by our valued partner, Edifecs. As the Office of Inspector General continues to audit coding practices and in-home assessment validity, now is the time to ensure your risk adjustment operation isn't exposing your organization to regulatory risk and penalties. In today's webinar, you'll hear the strategic adjustments industry experts recommend implementing so you can be confident in your ability to sustain value-based care reimbursements compliantly and accurately as CMS continues to refine practices. We are joined today by 2 experts from Edifecs who will be leading the discussion and presentation, Shayan Karamboy, VP of Product Management and Risk Adjustment, and Aaron Kaur, Director of Risk Adjustment. Shayan, Aaron, the floor is yours.
Thanks, Bill. Good afternoon, everyone. We appreciate you taking time out of your busy schedules to attend this. We're hoping that this session is going to be informative to all of you, and you can take back to your organization a few nuggets of information, a few tidbits that will help you improve your risk adjustment processes. As Bill put it, this session, we're going to really focus on some of the dynamics that we're seeing changing from a risk adjustment standpoint. In our work with both payers and providers, the intent is really to synthesize some of the learnings that we have seen into the 3 risk adjustment moves that we think will be very impactful and beneficial to your organizations, regardless of whether you're a payer or a provider. By way of introduction, as Bill said, my name is Shayan Karamboy. I'm responsible for our risk adjustment product line here at Edifecs, and I'm joined by Aaron Kaur, who's our risk adjustment subject matter expert on the Edifecs side. And for those who don't know Edifecs, we are a healthcare IT vendor. We have been in this space for 26 years. Our primary focus is really around revenue cycle and interoperability. We work with both payers and providers in several areas, ranging from standards-based data exchange to risk adjustment, which is a key focus area for us, and value-based care contracting, as well as prior authorization. On the risk adjustment side specifically, we work with several of the large national health plans, the large Blues plans, as well as some of the smaller regional health plans. And we also uniquely work with providers, whether it's health systems, whether it's independent provider groups, whether it's small, mid, or large ACOs. So lots of experience working on really both sides, payers and providers. And it's a very interesting time and dynamic right now as we see more and more collaboration between organizations as they take on more risk and partner around risk adjustment. And so with that said, I'm going to hand it over to Erin to kick things off. Erin?
Thanks, Cheyenne. So today, to kind of start off, we're going to just level set. Again, I want to thank you all for joining us for this hour. As we close out the 8th month of 2023, we really are starting to look back and as well as look forward. We really have to start planning and thinking about where are we going in the next 6 months? What's next year going to look like? But not only that, what's the next 2, 3, 5, and 10 years going to look like in the Medicare Advantage world, in the Medicare managed care organization, or the Medicaid, managed care organization world, and in the ACA world when it comes to risk adjustment. So, really thinking about what the whole purpose of risk adjustment is really to make sure that we're capturing through data, through that data exchange, the true and accurate burden of illness for whatever population you're working with. Again, whether that's the Medicare Advantage population, your MSSP, the new ACO REACH population, your ACA or your Medicaid population, we want to make sure that we're accurately submitting data to CMS so that they're reimbursing us correctly. And again, we want to make sure that the health plans have that compensation there that's fair so that we can meet those needs, those healthcare needs, and those healthcare costs of our patients and our members. But we also want to make sure that we're reducing the effects of that inadvertent or unintentional risk selection and discouraging any bias. Okay, so we want to make sure that we're selecting a fair and balanced member population so that we have that health equity, that we meet the needs of all members within these plans that are available to us. And then ultimately, the biggest thing here is and we've all heard this as we've been listening to the news and CMS and the OIG, is really we have to protect the financial soundness of our taxpayer dollars. That Medicare trust fund is so important for us to protect and make sure that we play our part in utilizing those taxpayer dollars appropriately. So going to the next slide, we kind of looked at some of the external and internal forces that were really impacting risk adjustment programs right now. And boy, this year has been a journey, to say the least, in changes, just the changes in the risk adjustment models. We all knew that changes were coming. Did we expect that the final notice would drop in March? Yes. Did we expect it to be retroactive? Not necessarily. We're very used to getting that information, being able to digest it, get it into our systems for that coming year. So the fact that March 31st, we get this notice that says, oh, by the way, we're going to start this on January 1st of 2023. It really kind of set some of us and the whole industry into a little bit of a tailspin. And we had to really readjust very, very quickly. And knowing that the changes that were made in those risk adjustment models were going to impact all areas of the industry financially. And so we really have to become much more efficient, much more accurate, and much more productive in utilizing our resources. And then on top of that, we also get increased auditing. So, if you think about it and you start looking back to like when the last RADV audit was done, you're looking at 2015. So Con 15 was the last RADV audit. And as of this month, it's still not done. So there's been a lot of things going on between, when they started the Con 15 RADV audit to now. And what happened is the OIG stepped in. And we started, looking at the OIG kind of started pulling in these audits that were being done. And, to date, they've published 23 audits on major health plans. Now, they've done a lot more. They just haven't had them published yet because they're still working through that process. But, 23 audits have been published to date. And really, we're looking at an average error rate that they're finding in these OIG audits, specifically around those, what they're calling the dirty dozen. So you're talking about your 12, I think it's actually 11 areas, focus areas that the OIG's been looking at. The average error rate is right around 78%. And the last few published reports, we're looking at upwards of 90+% error rates. So we've got a lot of work to do. So, how do we become more efficient and more accurate so that our audits are looking better? We're not losing the financial losses that can come from penalties and things like that. So we're going to talk a little bit about some of those strategies here in a little bit. But the only other thing is that we do have some of these other issues that are coming, and are here actually, is that's a strain on our existing resources. We just don't have the people that we need. There's labor shortages, the high level of knowledge that needs to come when we're selecting codings and documentation and reviewing those kind of things. And really the inability right now to address increasing volume. So how do we get more? Sometimes we look to the answer is to get more, we got to review more. Well, that can't necessarily be the way we go anymore. It needs to be, how do I get more? I work smarter, not harder. So more is not necessarily the answer. It's utilizing the technological advances that we have to help us work smarter. So how do we do that? Cheyenne and I kind of took a look at this and looked at 3 different ways that we feel like we can help the industry to move forward, and moves that you can make now. The first one is really to enable that accuracy and efficiency. Utilize the technology that's out there. Use those natural language processing tools and AI opportunities to really automate and improve that accuracy. This is where you have technology that really can augment the human touches that have to happen in this industry. So healthcare is never going to be truly AI automated or NLP automated. We're never going to get there. But we absolutely can use it to augment and become much more accurate, more efficient, and more productive. Number 2, we looked at emphasizing documentation and compliance. Helping our providers and our clinicians understand how important documentation is, and how medical documentation speaks to coding, and how the two don't necessarily speak well together, and utilizing your trained risk adjustment coders and CDI specialists to bring and bridge those two gaps together. Okay, but also shifting the work from retrospective, or picking up the pieces on the back end, to prospective and upstream activities. So doing those pre-visit CDI plannings prior to the patient coming in the door. Not only is this going to help us in the risk adjustment world and capturing those conditions and that full burden of illness, but it allows our providers and our clinicians to spend more quality time with the member, with the patient, to be able to get them good quality of care. Because they're not having to spend the time combing through thousands of different pages in that EMR system to find, what do I need to know about this patient before I go in the door, okay? And then number 3 is really absolutely important in establishing an end-to-end performance management framework. Make sure that you are doing that end-to-end look at and management of what is happening within your organization. On top of that performance management framework and having that good end-to-end workflow and processes is to be constantly checking to make sure you're meeting those compliance needs and the regulatory requirements that are out there. It's so important that anybody who touches risk adjustment in any way knows what regulations there are and has at least been introduced to those, so that they have that in the back of their mind at all times. So now we're gonna do here is Cheyenne's gonna kind of do a deeper dive into each of these 3 areas. Cheyenne?
Thanks, Erin. So the first area that Erin had kind of teed up was the ability to improve both accuracy and efficiency. And before we kind of delve into some of the benefits or some of the factors that we suggest you take a look at, I wanted to highlight some of the macro factors that we touched upon. So if we think about where we're at today, we have more and more patient or member data being generated. We're seeing more and more of that data being digitally generated through the advent of the EHRs. We're seeing more and more scrutiny on risk adjustment through audits, through some of the regulatory changes coming down. And we're seeing more and more variance and complexity being introduced in risk adjustment, especially now with the move from version 24 to version 28. So you kind of have this one bolus where we have more to do that's also more complicated. And when you couple that with the fact that we have fewer resources and a strain on resources, you're really kind of looking at the makings of a perfect storm. Do more and more accurately with less. And so something's got to give, right? I mean, it's, as Erin put it, you want to not necessarily work harder because you're capped out on capacity. And the more you push, you're going to have quality issues, but you need to work smarter. And that's where we see NLP and AI and machine learning coming in and really helping both payers and providers drive efficiency, drive accuracy to the next level, use automation that introduces in order to make more and more benefit to you. And it's interesting because especially as we sit here now and today, AI is all over the news, whether you look at ChatGPT or any of the other kind of big NLP AI areas coming out. But interestingly enough, this has been in healthcare for some time. For instance, we at Edifecs here, we have been focused on NLP and AI for several years, and specifically within risk adjustment. So this is not a new concept, and that's really important because you have, whenever there's kind of this hot buzzword and influx of people that run to that and say, hey, we do this and we do that, but you really want to look at track record and experience, because when you look at NLP, especially when we look at it from a risk adjustment standpoint, what we're looking to do from a healthcare and risk adjustments perspective is really complicated and really hard. We're looking to be able to not only automatically review these records, but we're trying to understand and identify what the risk acuity of these members are. What are the conditions that have been documented or stated or assessed in these records, which is very hard to do when you're looking at a tool and automation. And what you really need to look at is not all NLP AI engines are created equally. So if you're really looking to get to accuracy and efficiency at the next level, you really want to look at a solution that's been out there for some time, that's actually had a track record of driving better accuracy and efficiency. So that's one of the factors to look at. But it isn't just NLP. When I say NLP, the intent is, remember, it's accuracy as well as efficiency. And when you look at both of those together, especially efficiency, there's a lot that you want to look at in order to drive better efficiency, because there's a lot of manual processes that currently exist within the retrospective space or even the prospective space. So for instance, you're looking at, how do you identify what work needs to be done? How do you prioritize what needs to be done first versus second? And how do you have an efficient way of managing and measuring and tracking that? And so when you look at a solution that you want to use, you want to look at a solution that helps in a few different areas. You want to look at, how does it help me improve operational efficiencies? How does it cater to my operations? Because we see a wide variance in workflows, and how one payer versus a health system or even a payer and another payer do things are very different. Some have in-house coders, some use vendors, some use a combination of it. They have different coding guidelines, and they have different processes that they use. So you want to use and implement a solution that helps really cater to not only your current workflows, but also how you'd like to transform those over time. The second one is making sure that as we look at mitigating risk and looking at ensuring compliance, that the solution supports a two-way look. It is not good enough to only look at incremental conditions that are being left on the table. You want to make sure that those conditions are being appropriately documented. And if you're getting claims from providers, you're making sure that the claims are in fact backed up by evidence in the note, especially, as Erin mentioned, the scrutiny on audit. So a solution that helps operational efficiencies, but also helps mitigate risk, allows for a two-way look. And then the third element would be around, how does it help me measure, monitor KPIs? How do I get the transparency of how am I doing right now? Where am I behind? Where am I ahead? So I can load balance the work, and also be able to identify where I may have risk in my process and address that. So the ability really here is to be able to use a system that's got a sophisticated NLP that helps you drive to the next level of accuracy and efficiency, but also all the workflow-centric capabilities that you would be looking for in order to support your workflows and processes, and then having a way that helps you manage and monitor operational as well as strategic KPIs. So that'd be kind of the first bucket here on how we suggest you look at NLP AI to take you to the next level, not just the NLP AI component of it, but also the workflow component of it that helps you make that trade-off or solve kind of that perfect storm around do more and more accurately with fewer resources. The next one that Erin had highlighted was, how do we help drive better documentation and compliance? And if we look at the state of risk adjustments so far, though it's changing, we'd say over the past few years, there's been an overemphasis on retrospective activities. Risk adjustment has, for the most part, tended to be a payer-led function, a payer responsibility, not to mean that providers haven't been doing it, but it's been a lot of initiation by payers. Where retrospective has kind of dominated risk adjustment. The dominant portion of that has been retrieving records, having a team of coders vet those records to identify what's missing. and then to a certain extent be able to provide that feedback back to providers. And that's been kind of the extent of prospective activities, is the ability to partner with your providers, give them like a gap list or a chase list, and have them drive some of those gap closure activities and pray for the best. And that puts a lot of strain and a lot of burden on retrospective activities. And quite honestly, it limits the impact, because if you think about the whole focus of risk adjustment and CMS, the intent was this not being purely a financially driven exercise where you're looking to review charts after the fact and look at what's missed. The intent is really around how do we equip our providers in order to understand the risk security? How do we allow them to have that data at their fingertips when the patients are coming in to see them? And so they're not just focused on the reason for visit or why the patient came in there, but take the opportunity also to do a head-to-toe assessment of what are some of the chronic conditions, what's going on with the patient. In some cases, it may alter the care plan, but in a lot of cases, it just makes sure that they're being monitored and controlled on their medications and some of their risk on their chronic conditions. So the intent is really prospective. It's been focused on retrospective, but prospective is where we really have the patient care delivery impact, where we can impact how care is delivered and how do we improve that. And so our next emphasis here is how do we equip our partners to strike a balance, because there is value in retrospective. Retrospective is not going away. You still want to be able to do a catch-all, but you want to be able to share and spread that effort in prospective and balance it with retrospective. Because the more and more you focus on prospective and catching these gaps upstream, the less burden it's going to put on the retrospective programs and retrospective activities. And in a lot of cases, there are things that the retrospective programs can't capture. So for instance, you may have patients with chronic conditions, but when you open up the note, you're seeing that the provider hasn't done anything to document, administer, assess those conditions, right? So you're losing risk acuity there in the back end of the process, unless you equip kind of the providers on the prospective pieces and drive graceful ways of integrating that into their workflow. So that's the second emphasis on how do you do that? How do you strike a balance between prospective and retrospective? How do you allow for prospective programs and partnering with providers in order to be able to be done efficiently and cost effectively? Because in reality, one of the big sticking points on the provider side is that they are also strained for resources. The physicians are being pressed to do more and more with a shorter appointment time. And so in order to impact care and impact risk adjustment, this needs to really be integrated in a graceful fashion on the prospective side. So when we look at prospective, we kind of break it up into three main components. And we, through our experience with providers, see providers that may start with one and then expand to the others. Or we may see someone that does all three at the same time. So it really varies on the aptitude of the providers, the experience and maturity from a risk adjustment standpoint. And we see this as much as it is a technology opportunity, it's also a partner and collaboration opportunity, because in a lot of cases, providers need some of the expertise and experience on folks that have done risk adjustment, that have had experience doing it with several different providers, understand some of the changes and variances in order to guide what makes the most sense for them. But in a nutshell, we kind of break it up into three logical components. The first area from a prospective standpoint is how do you uncover gaps within your patient population? How do you identify what are the patients that have the gaps and what gaps do they have? In a lot of cases, this tends to be very limited on the provider side, where they largely rely on gap lists from their payer partners, which tell them, hey, these are the HCCs that we are finding on your patient population. And so use that in order to figure out who are the patients that you need to bring in for visits, or use the opportunity to review those as part of your annual wellness visits. And in a lot of cases, this is very limiting, because the payers, and when they provide the gap list, firstly, have data based only on claims. The data that's given to providers is also very limited. I mean, there's not a whole lot of evidence in order to support why is that gap existing, where is the source of that data. And in reality, providers are sitting on a lot more richer content already based on the EHR, based on all the clinical data that they have. So the intent here is equipping providers in order to do a much more robust analysis in an automated fashion as to what are the gaps that I have on my patient population, how do I risk stratify those on who are the high-risk members, the medium-risk members, and the low-risk members, using not only the payer data, but using the data that they actually have already through the clinical notes, the care plans, the visits, and all the other supporting information that they have in the EHR. And that's where the NLP machine learning comes in, the ability to uncover and discover those gaps in an automated fashion based on an aggregation of all that information. The next one is going to be, how do you actually use that information, not only to bring patients in, but when they're seeing the physician, be able to surface those gaps in a thoughtful fashion to the providers. So it makes sense, and you see a high acceptance rate as well as a high gap closure rate. And when I say a gap closure rate, it doesn't mean that all the gaps being put in front of the providers are accepted. It's really around being able to raise those to the forefront of the physicians so that they can make an informed clinical decision. They can make sure that they're asking the patient the right questions around those conditions, making sure that the patients are well monitored or they're on the right medications, and optimizing the care plan at the point of care. And to do that in a way that's graceful, that's not going to add more clicks to the providers, and do it in a way that's helping them provide better care is really, really important. And then third process is, once the encounter and the visit is completed, the provider completes their narrative on the encounter note, the ability to do a two-way look before the claim goes out the door. Because in a lot of cases, what you want to make sure is that the claim has conditions that have supporting evidence. And if there's not a lack of supporting evidence, those are not being put on the claim. And so if you're going to see the trend here, the more and more that you do prospective activities, identifying where the gaps are, assessing the conditions at the point of care, making sure that the claim appropriately represents the risk acuity of the patient, you're reducing kind of the downstream burden on retrospective activities. And the retrospective activities can focus more on really looking for the needles in a haystack, as well as partnering and collaborating more with providers in order to excel and improve that process even more. So I'll pause there, and I'd love to kind of get your thoughts, since you work very closely with a lot of providers and CDI teams, on any suggestions that you have for folks attending this webinar.
Yeah, thanks, Cheyenne. So, really my biggest advice right now for this particular section is to invest in CDI specialists. Use your resources to their fullest, the top of their licenses, the top of their certifications. So for your pre-visit reviews, utilize your CDI specialists, pull in your nurses, your LVNs, your medical assistants to do that kind of parsing for the clinicians, so that at point of care, they're receiving clinically relevant, meaningful, a meaningful compilation. Is that a word? I just made it up if it is. Of all of that information to really help them with that. And then on the post-visit side, and that post-visit encounter, is utilize your risk-trained coders to really analyze that documentation. And like I said earlier, is being able to have those risk coders be that bridge between how medicine talks and how coding talks, because there really is a gap there. And so you need those experts, those expert coders and clinicians to bridge that gap.
Awesome. Thanks, Erin. So that's a little bit on the prospective side, the three, steps that we see providers struggle with and capabilities that we think will really benefit the prospective activities. The last one that Erin had mentioned is, the classic saying, measure what matters. And we see this happening far too often is, risk adjustment by nature. There's a lot of moving pieces, not only between payers and providers, but even within a payer or provider organization. You have different teams doing different things, which is logical, right? Because each focus is a very specialized focus. But at the end of the day, it's really, really important for both payers and providers to be able to manage this from an end-to-end standpoint. So across the silos, the ability to manage effectiveness and efficiency. And a classic point is we're working with one of our earlier customers, and with the pandemic, there was a lot of turmoil and change that they were noticing in terms of where they thought that they would want to be at and where they were at. And they had this struggle around being able to figure out, well, where does my issue lie? Is my issue around analytics, where I didn't identify the right patients or the members? Was it around retrieval, where due to the pandemic, I was unable to get the records that I needed from my providers? Was it around coding and auditing, where with the work from home dynamic, I was seeing a drop off in quality? Or did I have leakage in my submission process? And unless you have a way of holistically being able to measure that, you don't know. And the intent is not to ask these questions right at the tail end of the process, where there's little you can do. it's the ability to manage this in real time on an ongoing basis. And I know like a lot of these statistics will look like a big number, but these are, the typical averages that we typically see in our customer base before we get engaged. And I'll start from the top and kind of work my way down. From a provider standpoint, we're seeing kind of to the point that I made earlier, a lot of providers are not able to accurately detect who are the patients that are my highest risk members or patients that I need to proactively engage with. They rely too much on the gap list by payers, and while the information there is good, it's hard for it to be actionable since it's not got any clinical evidence supporting it. And most importantly, it's not leveraging the clinical data they already have that can better identify risk acuity of their members than purely claims. So we see a drop-off in the ability to detect when they're relying solely on payer data. The next one and the next big drop-off is that far too often providers use this gap list towards the tail end of the year. They get these gap lists in the September, October timeframe, and they have kind of what we classically call as the cattle call at the end of the year, where they're trying to feverishly bring patients in order to complete their annual wellness visits, which they haven't had so far. The issue with that process is, again, you're up against the holidays, and it's really, really hard to get patients in the door during that time. And so the intent really is being more proactive and more deliberate about this in the front half of the process, where you do a better job on identification, but you also do a better job on engaging with these high-risk patients and proactively get them in for their AWEs. The third big drop-off that we see there is that the patient now comes in, the percentage that have actually come in, and the physicians are so focused on, focusing on the care as to why they came in, whether it's, COVID or some sort of an illness or some sort of an event, that they forget to assess all the other risk adjustment conditions that these patients have. And so what that results in is a big drop off in terms of patients that have conditions, because a lot of these may be chronic conditions, but there's insufficient supporting evidence in the encounter narrative and the note to back it up. And when that happens, there's little you can do in the rest of the process because you can only pick up things that actually have enough meat and tamper to support it. The next one is things that may have enough documentation, but that got missed on the claim. And so while there was documentation, it wasn't necessarily put on the claim. And those are opportunities that will only get picked up in the retrospective review now. As we move over, you may have a certain amount of drop-off due to the clearinghouse rejecting claims, and some of those claims are risk-eligible claims, and so you have some drop-off if that was the only HCC that was in that claim. But then you have a huge drop-off as you enter the payer cycle on the retrospective reviews, where, again, analytics that the payers use is largely insufficient in targeting the right charts. And the reason, again, for that is because similar to the gap list being generated on the provider side, the payers use largely claims data to do that. And so when you have a lot of agents from a MA standpoint, a lot of times those claims did not have all the conditions documented correctly. And so using just claims makes you miss that. We have between now, as we move from version 24 to version 28, there are new conditions being introduced every time. And again, those haven't been put on the claim before. So until and unless you uncover the charts that you're already sitting on, you're actually doing only a partial job on suspecting and targeting the right members. And so there's a lot of value in focusing on how do I do a better job there. You have a drop-off from a retrieval standpoint, and we're seeing this as a continued challenge for payers right now, especially due to the pandemic and some of the strain and burden that providers have is just them not being able to get the charts in a timely fashion. And we're seeing that being soon to be addressed, I think, with more and more digitization, more and more focus from CMS around electronic transmission of data between payers and providers. And we're very supportive of that. I think this is going to be a huge win for the community. And we have areas that we help our payers and providers with as well around electronic data exchange. Another limiter there really is around how do you make that as a graceful process, because in order for a payer to get data, there's typically a big burden on the provider organizations to support that activity, and they don't have the resources to put that burden on it. So anything that payers can do in order to make this as a seamless and a graceful exercise for providers is going to help with the overall adoption. And then you get to the drop-off around you've got the records, you need to now code it, and there's quality issues that we typically see. And we know 95% has kind of been this industry standard out there. But in our experience working with several customers on the payer side who use a variety of different coding vendors, I will say that the reality is far from that. In reality, when we actually look at accuracy for coders, there's a big variance. You have the A coders that perform at 95% plus, but you have a lot of B and C coders. And when you especially vendor this out, the composition of coders that are assigned to you is always going to be a mixed bag, right? You're never going to have all the A plus coders from a facility. You're always going to have a mix of A, B, and C. And then your job is really how do you keep the A's, how to improve and identify performance in the Bs, and how do you change, manage, and performance manage the Cs, right? And so you really need a system that allows you to be more effective and more strategic at looking at what is my coder bench look like, who are my A players, who are my middle of the road performers that need to improve, and then who are the C players that need more scrutiny. And the more you do that, you can now start getting to the 95% mark, and even a few percentage points there have a huge impact to your overall bottom line. And the last part is we see leakage, especially since we do both coding and submissions from customers. And when we engage with new prospects, we kind of see their acceptance rates that are not where they need to be. You really want to drive to an acceptance rate that's over 99% or even more. And that's been our experience. We see a lot of drop off there as well. So when you kind of put all these percentages together, it's actually eye-opening when you look at the overall risk acuity being missed between prospective and retrospective activities. And the intent here is whether you're a payer provider to really focus on where some of the pain points are. And as I put it, the intent is not perhaps to do a big bang where you're going to address everything at one fell swoop, but the intent is to at least have a way of managing and monitoring this so that you know where is my biggest drop off, how do I invest in those activities, and then over time, expand and scale out more and more to invest in the other areas. So that's number 3. We talked about NLP and AI in order to drive better and better automation. We talked about investing in prospective activities. And then we talked about 3, measure what matters, having a way of actually managing and monitoring performance. That's ultimately going to figure out, where am I excelling in, where do I need to improve, and then how do I drive investment and change management in those areas. So I'll pause there. Erin, anything else that you'd like to add in any of the 3 areas?
Yeah, the only thing that I would add is overall is the slide that Cheyenne just walked us through, has a lot of opportunities on both the payer side and the provider side where there is potential leakage. And we all tend to want to tackle it all at the same time. And like Cheyenne said, you don't have to do that, is to take a look at your organization, take a look at one specific area, get a good work plan together, and start taking little tiny bites at this to start, moving forward in the right direction. The only other thing that I would really add to this is that I'm going to kind of put my compliance hat on right now, is then that everything that you do, make sure that you have good policies and procedures written down to support what you're doing, why you're doing it, and the consistency is there in the processes that you're going to do. So when those regulatory agencies do come in the door, the first thing they're going to ask you for is those policies and procedures. And you're going to want to be able to say, I've taken a small chunk out of what I know are issues here or areas that I need to work on. And here are my policies and procedures for that. The OIG and the CMS agency is looking at being partners with us and really want to know that we're doing our best due diligence, that we're making our best efforts to move the whole industry forward. So really make sure that you are thoughtful and that you are documenting and that you are compliant.
Awesome. And the last slide we had was, just giving an overview of what we do from a risk adjustment standpoint. As I mentioned at the start of this webinar, we partner with both health plans and providers. So it really helps from an experience standpoint because we're seeing more and more from a macro trend standpoint, greater and greater collaboration. And we're very supportive of that because in order to risk adjustment correctly, and in fact, to succeed in value-based care as a whole, it's really important for that collaboration to continue. And there's things that payers can do, there's things that providers can do, and there's things that they can do together. And our solution suite supports all of those things. So we look at starting out from the left, We have several customers that use our NLP AI engine for suspecting purposes. So the ability to take in data, whether it's claims information or EHR data or medical charts, and be able to assess and analyze, where is my risk? What are the conditions that you're finding in these documents, in these claims, that I need to do proactive action on? And the action can be either I'm going to use it for retrospective purposes, where I want to chase charts to close those gaps, or prospective purposes, where these gaps really need to be surfaced to providers at the point of care so that they can take action proactively. The next one is retrieval. As I'd mentioned, we work with several health systems, payers, and providers around retrieval. How do we create a way to seamlessly get data from providers over to the payers, as well as help providers kind of consolidate their data across the EHRs to be able to use it for risk adjustment purposes? We have both a clinical and a coding suite. They work differently because the NLP has different logic on both. From a clinical standpoint, when providers use our risk adjustment NLP AI tools, they're really looking for, what are the conditions that you can see in these records? Where's the evidence based on a medication or a lab or things like that? That's going to help us understand, what are the conditions that my members have or patients have. When we get to the coding suite, our NLP AI engine works slightly differently, because a condition may be documented, but it may also not be documented. And so from a coding standpoint, as you look at retrospective activities, you can only pick up things that are documented. And so the NLP AI engine is oriented to be able to do that, because we don't want to create noise for the coders. We don't want to create noise for the end users, and we want them to be as accurate and as efficient as possible. The intent is also to do a two-way look. You want to look at both things that have been missed as well as incorrectly submitted, in order to drive better and more accurate documentation and coding. As that's done, we have a submission solution that supports all lines of business, Medicare, ACA, as well as Medicaid. Each of the Medicaid states has their own state-specific requirements from a submission standpoint. And so that's a huge focus area for us, where we don't want to just support MA and ACA. We want to have customers that can use our submission solution for all their lines of business as a unified strategy. And last but not least, a performance management suite. There's some analytics that we do, especially on value-based care contracting, that helps payers and providers understand and assess performance, taking into account not only risk, but quality. But we also have operational metrics that help us monitor and allow customers to manage productivity, accuracy, and other types of benchmarking and tracking. As Erin said, the intent is, we don't see any organization that may start with like a big bang approach. The intent is, depending on where your pain points are, that is really the best starting point. And then expanding from there as you want to do more and more end-to-end performance management and layer on additional solutions or address other problem areas over time. With that said, that brings us to the end of the webinar, and we'll open up for any questions. Bill, team, maybe you can let us know as questions trickle in.
Happy to do so, Shayan. Looks like we have a question coming into the chat here. Does anyone here know if there's a plan to enhance the ANSI X12 837 transactions to remove the restriction for the number of diagnosis codes that can be sent? Currently, I believe for 837I, it's restricted to 12, and 837P, it's restricted to 25.
Yes, I love that. Stephanie, thank you so much for that question. So you're right. We do have some really big limitations. We have not heard in the industry any noise around whether they're going to expand those, but it's definitely something that industry leaders are starting to talk about, because as we start looking at the concept of health equity, social determinants of health, HCCs, you start losing real estate very, very quickly. So you start thinking about, I need to make sure that my diagnosis codes that map to payable HCCs are pushed to the front, but then I need to make sure that I capture that my Z codes for my SDOHs and my health and equity, but I also need to make sure I'm capturing my past medical histories and that are pertinent and things like that. So we really are starting to push for the fact that in order to get the information that CMS and HHS is wanting, we don't have the real estate. Now, one of the things that we can do at this point, of course, is not necessarily the most efficient, but it is our workaround right now, is to utilize that 994. I'm going to lose the code. The penny code, the zero pay CPT codes, where you can add those additional diagnosis codes onto that encounter. So until we can really get that covered, we need to make sure we can get that change made. We really need to have conversations at the provider level, at the rev cycle level, as to how to categorize and place those ICD-10 codes in the right orders. Great question. It's always at the top of the mind of us who are trying to capture everything we're supposed to.
All right, and thank you too, Erin, for the elaborate answer. We appreciate that. Any other questions from the audience? Feel free to raise your hand using the reactions option in the menu bar at the bottom of the Zoom screen, or you can enter those in the chat anytime. All right. Well, unless we see, give folks a moment or two to type just in case they're out there punching their keyboard and getting that that question entered in. Shion, Erin, in the interim, would like to thank you both very much for being here today. Thank you very much for sharing all of your insights. Obviously, questions are still out there and need to be answered. Folks in the audience, if something comes up in the future, what's the best way to follow up with you?
Bill, we can send you our email. I think email would be a great way to follow up.
Excellent. That sounds
Email
perfect.
or LinkedIn. Feel free to catch us on LinkedIn or anything. We're always here to answer questions, do what we can, and I love to talk to anybody about risk adjustment who's willing to listen, because there's so few of us.
That sounds wonderful. Thank you both. And yes, for the folks in the audience, if you do have any follow-up questions, feel free to send those to us at weedy@weedy.org, or as both Shion and Erin had mentioned, feel free to reach out on LinkedIn, or we can pass your questions along. But again, Shion, Erin, thank you very much for your time and sharing your insights today. We appreciate it, value the partnership with Edifecs, and look forward to continuing to work with you both. For everyone else, we encourage you to check out the Weedy event calendar. We do have a few events coming up next month. There is a virtual spotlight on healthcare and artificial intelligence, looking at the steps to take when planning out the implementation of an AI solution. So if you've not thought about the governance required there, a great session coming up for you. The Weedy National Conference is also coming up November 6th through the 9th, and we look forward to having you all join us there, including our partners at Edifecs. So thank you once again for your time today. And to Cheryl's question about sending out the handouts, Shion, we'll connect with you afterwards for the slides. And yes, we'll get those out to you, Cheryl. But thank you very much, and I hope you all have a wonderful day.
Thank you all. Take care.
See you guys. Bye.